Hypogonadism is a condition in which the male testes or the female ovaries produce little or no sex hormones. It is caused by a lack of hormones that normally stimulate the ovaries or testes. Normally, the hypothalamus in the brain releases GnRH. This hormone stimulates the pituitary gland to release FSH and LH. These hormones tell the female ovaries or the male testes to release hormones that lead to normal sexual development in puberty, normal menstrual cycles, estrogen levels, and fertility in adult women, and normal testosterone production and sperm production in adult men. Any change in this hormone release chain causes a lack of sex hormones. This prevents normal sexual maturity in children and normal function of the testicles or ovaries in adults. Primary hypogonadism is due to disorders affecting testicular or ovarian structure or function directly, while secondary gonadal failure is due to hypothalamic pituitary disorders. There are several causes of hypogonadism: damage to the pituitary gland or hypothalamus from surgery, injury, tumour, infection or radiation, genetic defects, high doses or long-term use of opioid or anabolic steroids, which in essence are high dose of testosterone, drug use such as heroin or use or abuse of prescription opiate medicines, severe stress, high prolactin level, a different hormone released by the pituitary, long-term or chronic medical diseases including chronic inflammation or infections, weight loss. Symptoms: in children, lack of growth and sexual development at the standard age for puberty. Pubertal development may be very late or incomplete. In boys, no development of sex characteristics such as enlargement of the testes and penis, deepening of the voice, and facial hair. Affected children may complain of relatively short stature. In girls, a lack of breast development and menstrual periods. Adults, loss of interest in sex or libido, mood changes, infertility, loss of menstrual periods, amenorrhea in women, decreased energy and interest in activities, loss of muscle mass and weight gain in both men and women. Blood tests to measure hormone levels such as LH, prolactin, testosterone, FSH, TSH, and estradiol. Blood tests to check for iron level if hemochromatosis is suspected. MRI of the pituitary gland and hypothalamus to look for a tumour or other growth. Genetic testing. LH response to GnRH. Treatment. Behavioural modification and psychological counselling may benefit individuals with hypothalamic amenorrhea. Such approaches should be offered before estrogen replacement therapy. However, if the amenorrhea persists for more than 6 to 12 months, despite successful non-pharmacological therapy, it is advisable to consider hormone replacement. Treatment depends on the source of the problem, but may involve injections of testosterone in males, slow-release testosterone skin patch in males, testosterone gels in males, estrogen and progesterone pills or skin patches in females, GnRH injections, HCG injections. Approach for secondary hypogonadism is based on age or etiology, for example, HCG and FSH for congenital hypogonadotrophic hypogonadism. Surgical care. Assisted reproductive technologies, including in vitro fertilization, IVF, zygote intrafallopian transfer, ZIFT, have been used successfully when male patients with idiopathic hypogonadotropic hypogonadism do not achieve adequate sperm counts on either GnRH or gonadotropin therapy.